Hello everyone, welcome back to Med-Surg Knowledge Nuggets, where we take big nursing topics and break them down into manageable, test-friendly content. Today we're talking about meningitis. Let's begin with what meningitis actually is. So meningitis is an inflammation of the meninges, which are the protective layers surrounding the brain and spinal cord. This inflammation can be acute or chronic and often stems from an infection, whether bacterial, viral, or even fungal in nature. You may also hear the term aseptic meningitis, which typically refers to viral causes and is often less severe, but it still needs our attention. From a nursing perspective, understanding the source of infection is key. Bacterial meningitis is a medical emergency, while viral forms are usually self-limiting. So let's talk about risk. Think crowded environments, college dorms, military barracks, and prisons. Close living quarters allow these infectious agents to spread rapidly, which is why vaccination and early identification matter so much in these populations. All right, so let's get into the clinical picture. Patients with meningitis often present with a sudden onset of fever, usually greater than 101. Also, they present with a severe headache that just doesn't go away. But what really raises red flags are the neurological changes like altered mental status, photophobia, and sometimes nausea and vomiting due to the increased intracranial pressure. So as nurses, you're going to want to watch out for the classic meningeal signs. The first one is Brzezinski sign. This is when flexing the neck causes the hips and knees to involuntarily flex, just like this picture. Then we have Kernig sign. This is resistance or pain when straightening the knee after hip flexion. Again, take a look at the picture. Other hallmark signs include nuchal rigidity, which is that unmistakable neck stiffness, and opisthotonos, which is when the patient's back arches and the head hyperextends. Again, take a look at this picture here. These are actually late signs and reflect severe irritation of the meninges. So document thoroughly and report changes immediately to the provider. Diagnosis. When it comes to confirming meningitis, we rely heavily on diagnostic testing. A head CT is usually done first, especially when there's any concern about increased intracranial pressure. Why? Because performing a lumbar puncture without ruling that out could be dangerous. Once it's safe, the lumbar puncture, it can also be called a spinal tap, is the gold standard. It allows us to analyze cerebrospinal fluid for signs of infection, inflammation, or bleeding. So as the nurse, you'll often be the one prepping the patient, supporting them through the procedure, and monitoring for complications like headache or bleeding afterward. You will also be responsible for ensuring that the specimens are labeled correctly and transported promptly to the lab because timing is everything in suspected meningitis. All right, so let's talk about treatment, complications, assessments, interventions, and teaching. So once meningitis is suspected, you don't wait. Broad spectrum antibiotics are started right away, even before confirmation from labs, because early treatment saves lives. As nurses, we have to advocate for that timely intervention and ensure it's being administered quickly and correctly. Because these antibiotics need to cross the blood-brain barrier, the choice of drug matters. Treatment usually will last 14 to 21 days, so long-term IV access will be needed, such as a PICC line or central venous catheter. That means that we're also going to be responsible for maintaining sterile technique, preventing infections, and educating patients about their line care, especially if they're going to be managing this at home when they are discharged. So treatment is only going to be part of the story. So meningitis can lead to serious complications. One of the biggest concerns is increased intracranial pressure, or ICP. So early signs can be subtle, like a change in level of consciousness, a new headache, or slowed pupil response. That's why frequent neuro checks are absolutely essential. And yes, dexamethasone might be ordered to reduce inflammation. That is a steroid, especially in cases of H. influenzae, but it's still actually debated in many protocols. Seizures can also occur due to the irritation of the cerebral cortex, so you want to make sure you place this patient on seizure precautions, and you want to anticipate anticonvulsants being ordered. Don't overlook endocrine complications. So SIADH can lead to fluid overload, while diabetes insipidus can result in dangerous dehydration. So that means you're going to keep a close eye on urine output, specific gravity, and your serum sodium levels. So as nurses, we need to make sure we're doing our assessments. That's going to include neuro checks, especially level of consciousness, meningeal signs like Brzezinski and Kernig sign. You want to make sure you do that only after confirming that there's no surgical spine injury. We're going to check our vital signs to make sure there's no vital sign changes that could indicate increased intracranial pressure, such as a widening pulse pressure, bradycardia, or irregular respirations. We're going to check fluid balance and perform daily weights because we want to make sure the patient isn't going into SIADH or DI. We're going to monitor renal labs because some of these antibiotics we're using could be nephrotoxic. We're also going to include cranial nerve assessments because we're going to watch for pupil changes and eye movement irregularities. Also, vascular checks because we want to make sure there's no signs of bleeding or clotting because this could actually be a sign of DIC. So your interventions are going to be just as important as your assessments. So we're going to administer fluids, and that's going to be based on their fluid status. You want to give antibiotics without delay. That is going to be your priority. You want to dim the lights, reduce noise, and create a calm space for the patient because they may be experiencing photophobia and stimulation can worsen their discomfort. You're going to keep the head of the bed elevated to at least 30 degrees, and that's going to help with increased intracranial pressure control. Manage pain holistically. That includes medications and comfort measures. We're going to follow transmission-based precautions. It's usually going to be droplet for bacterial meningitis. You're going to work to make sure you maintain normal thermia because high fevers can increase oxygen demand in an already stressed brain. Okay, so now that we have that covered, let's talk about teaching. Because nurses are educators, discharge planning is going to start from day one for all of our patients. You are going to need to stress and keep reinforcing the need to keep their follow-up appointments. Recovery is slow and long-term effects are possible, so they need to come back to their provider just to make sure everything is going okay. We also want to educate the importance of completing their antibiotics fully, even if symptoms improve. We want to let them know to recognize the signs of a recurrent infection or increased ICP, because if either of those things happen, they need to be treated quickly to prevent a crisis. You want to, if they are discharged with a central line, we're going to let them know how to manage that. Or manage medications at home, especially if they're discharged on IV therapy. By the time they go home, the goal is that the patient is neurologically stable, hemodynamically sound, and they know when to seek help. That is the full circle of the nurse in managing meningitis to protect the brain, manage the complications, and empower the patient. Nugget of meningitis. So meningitis is more than just an infection of the meninges. It is a neurological emergency that demands a sharp eye, quick action, and constant vigilance. So as nurses, we're not just giving antibiotics. We are monitoring for silent shifts in mental status that may signal rising intracranial pressure. We're balancing fluid therapy with the risk of SIADH or DI. We're also preventing secondary injury by controlling fever, managing pain, and minimizing stimulation. Thanks for watching. If this helped clarify things for you, make sure to like, comment, and subscribe for more Med-Surg knowledge nuggets just like this one.